What is the age range for which a new center should be comfortable and offer therapy? So the new center can treat patients between the age 2 and 15 years with no major comorbidities. However, they can refer younger infants and those with major comorbidities to a more experienced team. And if there is no team who can look after adult on ketogenic diet therapy, better not start treatment for patients older than 15 years of age. Should members of a center be formally trained? The answer is yes. And the training should include at least one training visit to an established ketogenic diet center and attending a training conference. And if possible, having a ketogenic diet team to travel to their center to help educate them in how to use this treatment. And in future, the training will be more on like video conference or social media videos or virtual workshop, which is happening now. And ideally, the duration of ketogenic diet training should be between 1 and 5 days. Which diet should be offered? Should all 4 dietary therapies be offered in the new ketogenic diet center? The members of the diet center should be familiar with all 4 dietary therapies, and they can decide based upon their comfort level and availability of resources which diet they can start. Which laboratory studies are mandatory? So at baseline, we have to do certain investigations which are really must, like sodium, potassium, bicarbonate, chloride, urea, creatinine, and glucose. However, fasting lipid level, liver function test, complete blood count, calcium, and vitamin D level are advised, but they are not mandatory. On follow-up, which is around 3 months or every 3 monthly, we have to do a fasting lipid profile, urine analysis, sodium, potassium, urea, creatinine, and bicarbonate. If possible, we can do vitamin D level, calcium, and liver function test. What is the basic supplementation for dietary therapies? All patients who are on ketogenic diet should be given multivitamins and vitamin D and a calcium supplement. The other supplements like carnitine, coconut oil, trace elements, MCT oil, oral citrates, these are optional. The oral citrate will be given to patients who are at risk of renal stones or if there is a family history of renal stones. And ketogenic diet formula should be offered to infants who are on liquid diet. Should a patient be admitted or fasted to start diet therapy? So the ILA is recommending to admit infants or patients with comorbidities to start the diet. However, low risk patients without any comorbidities, we can initiate the ketogenic diet as an outpatient, but they should be able to contact the ketogenic diet team in case of emergency. And the ketogenic diet team should be always available when they are contacted. How should follow-up support be handled? So the ketogenic diet team should be available at all times, either at the end of the phone. Nowadays, with the availability of social media and the improved technology, they can be contacted instantly, or if they can't speak to the doctor or the dietitian, they can send message in the social media like WhatsApp or Telegram. In case of any difficult issues, second opinion from a more experienced team should be sorted. Or written materials recommended. Preferably, the materials in the care provider's primary language should be given. But with the availability and improved technology, we can refer to this ILAV website because there are a lot of materials is available there. Right, so now I'm going to tell you what we are doing in our center. So it is a multi-specialty hospital which has 1,200 beds, and as I said, it is located in the southern part of India. And this is my ketogenic diet team. The one in the middle is me, and she is my secretary who helps in teaching patient as well as the parents how to do the urine dipstick test. And this is Mrs. Rajesh Srinivas, and she's our senior dietitian and who helps me with the diet. So what do I do? So after my training in UK, I came back to India and started my work in this hospital. And I wanted to do something different for the patients with refractory epilepsy. Then I found out Dr. Nathan has been doing ketogenic diet for quite a long time. So I contacted him and had my training in 2016 and started doing the ketogenic diet therapy from 2017. I'm comfortable giving ketogenic diet to patients from 0 to 18 years of age. And I give classical ketogenic diet, modified Atkins diet, and low glycemic index therapy. These are the investigations which I do at the baseline, like fasting lipid profile, calcium, complete blood count, creatinine, and liver function test. And on follow, which is 3 monthly, I do fasting lipid profile, complete blood count, liver function test, urine analysis, and urine spot calcium creatinine ratio. The supplements which I give to my patients is multivitamin, vitamin D, and calcium, along with potassium citrate. And I initiate diet only as an outpatient, and I don't admit patients to start the ketogenic diet because I don't fast them. And I follow them every 2 to 3 months. If they can't come for follow-up, it will be WhatsApp call. So we talk to them, either me or my secretary will talk to them and find out if there are any issues. And I will ask them to do the blood test locally and send the report to me in WhatsApp. And I refer Dr. Nathan's website for more information and interesting recipes. The challenges which I come across or my patient come across is the cost when we start them on ketogenic diet, because many of our patients are from low socioeconomic status and they really can't afford to get soya milk or soya powder. So many patients could not continue with the ketogenic diet. But this COVID really made a lot of changes, because I advise them to start making the soya powder in their home with the help of the dietitian from Dr. Nathan's team. So now they make the soya powder in their home, so which is cost effective. And I'm concentrating more on low glycemic index ketogenic diet therapy and modified Atkins diet during this COVID era. So let me share a couple of my patient stories. The first one is a 17-year-old boy who is an ex-prem who had neonatal hypoglycemia. As a result, he had bilateral occipital gliosis. And he came to me early this year in March 2022, and he was on 6 antiepileptics. And still he was having breakthrough seizures, like 2 to 3 per week, which last for about 20 minutes. I started him on low glycemic index therapy, and I reviewed him last month. And interestingly, his seizures has reduced to 1 every 7 to 10 days, and the duration of seizure has reduced to less than 2 minutes from 20 minutes. And according to his mother, he's speaking more than he was before, because usually he's quiet, he doesn't speak to many people, but nowadays he started to initiate a conversation with others. My second patient is a 6-year-old boy with infantile neuronal ceroid lipofuscinosis, and he came to me, rather his parents came to me in 2018 because he was having continuous myoclonic jerks, and he's from far off place, so they could not bring the child to me. So they came with all the reports and they told me the history. And after getting permission from our management, I started ketogenic diet on this child, and follow him up through WhatsApp, because this child has been treated by the local neurologist. So that neurologist looking after the child, and I'm looking after the ketogenic diet, and I follow him up like virtually every 3 months with the follow-up blood test. And if there are any issues, his mother will contact me via WhatsApp, and I will call her back and sort of the queries. So I started him on classical ketogenic diet, starting from ratio from 1.5 and gradually increased to 2.5:1. Then his seizures gradually settled, and currently he is having only occasional eye jerks. And at present, he is on classical ketogenic diet 1.5:1 ratio. And the final patient is a 6-year-old child who had neonatal meningitis and intraventricular hemorrhage. He presented to me in 2020 with a history of myoclonic jerks, which happens at least 10 per day, and generalized tonic-clonic seizures 1 in every 2 to 3 days, lasting for about more than 5 minutes. He came with 4 anti-epileptics, and I started him on modified Atkins diet, and his seizures gradually settled, and his current status is he's having myoclonic jerks once in 2 to 3 days. And he did have a period of seizure-free, mainly for generalized tonic-clonic seizures, for 6 months after starting the modified Atkins diet. Now he's having every couple of so he's having generalized tonic-clonic seizures once in 7 to 10 days, but the duration is very short. So in conclusion, ketogenic diet center can be started in a resource limited setting with the following minimum requirements, like having a critical members with ketogenic diet training and mandatory investigations, which can be done to reduce the cost, and mandatory supplements, and we can reduce the cost by initiating the ketogenic diet as an outpatient, and follow-up can be done through mobile if they can't come to the hospital, but the ketogenic diet should be readily contactable via mobile, and we can give them online resources rather than printable materials to reduce the cost. I would like to thank Dr. Nathan and his team for the immense support they are providing to the whole team of doctors and dietitians in India who are doing the ketogenic diet for epilepsy patients. And I would like to thank my patients and their parents as well.
Thank you, Dr. Sujata, for a very nice and detailed talk on minimum requirements for ketogenic diet therapy centers. So without further wasting in time, I'll quickly move to my second speaker. She's Dr. Pyara Ratnajaike from Sri Lanka. She's a consultant pediatric neurologist. After her graduation from University of Colombo, she did her postgraduate degree from Postgraduate Institute of Medicine, University of Colombo, Sri Lanka, and she joined as consultant pediatric neurologist in one of the premier centers in Sri Lanka. She's the founder and organizer of the ketogenic diet program in Sri Lanka, in fact. And she has many titles and awards in her credit, starting from Chalmers Gold Medal in her medical school career, and many other, followed by George and Epilepsy Fellowship and one of the ILAE scholarship in way back in 2009. So in her professional career, she is the secretary of the Sri Lankan League Against Epilepsy and Epilepsy Association of Sri Lanka and International Bureau of Epilepsy and Sri Lankan Association for the Child Development. So I welcome Dr. Ratnajaike for her talk on, which is very important for practical problems of setting up the ketogenic diet therapy in Sri Lanka. Over to Dr. Pyara Ratnajaike.
Thank you, Dr. Sultan, for the kind words. And thank you, Dr. Nathan, sir, for giving me this opportunity, as well as for your continued support, as well as I'd like to thank the ILE also at the outset. So ketogenic diet difficulties in the practical difficulties in establishing centers in Sri Lanka is the topic that I'm going to talk about today. If you look at Sri Lanka, it's a country with a population close to 22 million, and our staple food, like in many of the Asian countries, is rice. So ketogenic diet in our country, as I think in many of the other parts of the world, is mainly used in pediatric epilepsy. At present, we have centers in Colombo, which is on the coast, Kandy, Galle, and several other areas in the country. Just to briefly update about what's happening here right now, in Colombo, we have about 400 patients who are registered in our diet clinic. Probably about 100 are active, others have sort of like gone through their diet and had either defaulted or had seizure control and stopped. So Kandy has around 35. Kandy, which is actually a beautiful town in the center of the country, has around 35 active patients. Galle used to have a very active program, which is not so active right now. And so many of the other centers in the country do have patients who are on the ketogenic diet, which is actually mainly used in the other centers around the country in the setting of acute seizure control, especially in status epilepticus. Okay, so just going back in history, the ketogenic diet was first started at the Lady Ritchie Hospital in Sri Lanka. You can see the hospital in the background here. It's a 1,000-bed, close to 1,000-bed hospital, supposed to be one of the largest pediatric hospitals in the world, way back in 2012. And in fact, I have to thank Dr. Nathan again. I think we traveled to his center, myself and a dietitian, Ms. Priyamada Amrasena, who's no longer in Sri Lanka. I'll need to thank her as well. Both of us traveled to the Indian center and attended a two-day workshop with another day of like practice and going around the center, and came back and established the center in Sri Lanka. So there were many enthusiastic people who helped at this time. So actually, rather than just talking about the difficulties, I thought I'll talk about the plus points as well. So at this time in 2012, we did not have anybody dealing with diet, nutrition, or anything like that at the Children's Hospital, but the dietitian, Ms. Priyamada Amrasena, from the close by adult hospital, about like more than half a kilometer away from our hospital. She's the one who helped us out at this time voluntarily without any remunerations. And the enthusiastic trainees, including Dr. Gamuheva Vitarana, helped with establishing the center. So the practical difficulties we had was the most difficult thing when you're starting this off new and nobody has heard about this, is that it is new. And because it's new, it's unfamiliar. And because it's new and unfamiliar, it's suspicious. So this was the main problem that we had, but it was very soon overcome because the patients who came to us and the pediatrician who referred the patients to us saw the good results of what we were doing. And this was not actually very difficult to overcome, although we had to hold few like educating workshops to the public as well as to the pediatricians who were the referral base to overcome this problem. So the other practical problem which we are still facing right up to now is the fact that our diet is rice-based. I think probably Dr. Manoji will be talking to you about this tomorrow, so I'll not go through that, but I think a lot of us share that problem. But again, the problem was actually that the parents, the main problem was that not that the children craved the rice, it was that the parents felt that their children were not fulfilled if they were not given rice. So with a little like talking to the parents and asking them to assess the behavior of the child and see actually whether the child craved the rice, this was easier to overcome that way. So the other difficulties were that there was no familiarity with how to start. There were no protocol, how to do side effect monitoring, and the equipment necessary for this, none of this was available. And I think right back in 2012, even the ketogenic diet website, even Dr. Nathan's very helpful website was not so like equipped as it is now. So probably we had many difficulties at that time, but these, if you are starting a new center now, these difficulties are actually no longer all that prevalent, because all this material is available nowadays to be got over the internet. Then when it comes to side effects, the side effects, although they were not very common, because we were unfamiliar with the side effects, again, there was a difficulty, some practical difficulties in management, but once we got familiar, these were not troubling at all. So monitoring facilities, equipment, recipes, and non-availability of like the food values for Sri Lankan food items, all these were problems at the beginning, but they were obviously not insurmountable problems. And with the dedication of the whole team, we were able to overcome these problems. But some of the practical difficulties we are still facing is that the monitoring facilities are quite expensive and not freely available to the patients. And sometimes we have to find sponsors for them. And also the equipment, even the weighing scales and things like that are quite expensive for the patients. And we have to sort of go on a patient-to-patient basis, finding donors for these the patients to sustain the ketogenic diet. So moving on from there, just to very briefly tell you, these are from one of the some of the children that very sort of early started on the diet in 2013. It was by end of 2012 that we started the diet. And you can see, as you look at this data, that about around 50% or more than 50%, around 50% had a 50% reduction in seizures, with 16%, 11 patients having 100% seizure control. And this is one of the factors that help to overcome the initial fear or the initial problems that the community and the referring pediatricians had regarding the diet. So actually getting together this data and circulating this data is another way of helping you out with the practical problems, because once people see the data, they are happier to refer the patients to you, and the patients in fact are happier to follow up the diet. And I think we have repeatedly talked about this, so I will not talk further about this. The cognitive behavioral developmental intervention was pleasing and at times astonishing. And this was one of the reasons. The practical, all the other practical problems that even motivated not only the pediatricians and the children, but even us, the team doing the ketogenic diet, to go ahead and go on with the interventions. Okay, just more practical problems. So this is Australia, as you know, Upper House, Sydney, 26 million people. This is neurologist in Sydney Children's Hospital, 10 of them. Very close by, you have the Westmead Children's Hospital where I got trained, 12 wonderful neurologists, some of them my good friends. So this is just for Sydney. And now come back to Sri Lanka. So this is the actual problem that we are having. 22 million people, 8 pediatric neurologists. So I have actually colored 3 of them in blue because some of them have various other specialized interests and other commitments and as well. Right? So the 8 pediatric neurologists have to serve the whole 22 million people. So the amount of like energy or the time you can spend for some specialized tasks that like this doing the ketogenic diet is not fantastic. So this is a problem that we are struggling to overcome it. And not only that, so this is just what the duties that I have to carry out. So ketogenic diet is not like just one of the multiple things that I have to do. So the like the energy or the time, especially the time more than anything else that I can spend on this, that I can spend on developing the system and troubleshooting all the things that we have to do becomes quite difficult. So then, so we have 22 million people who are on the rice-based diet, 8 BC pediatric neurologists. And we had great difficulties, practical difficulties from the nutrition side as well. Only very recently that we have nutrition services established in Sri Lanka. The dietitians are not widely available. And in fact, now we have a fantastic team which is helping us to keep the momentum going. And just to mention a few names, Dr. Angela De Silva, Dr. Pulan Lanro, some of the people as well as Dr. Malka and Manoj will be talking to you tomorrow with some of the people who helped us out without helping us, like doing the ketogenic diet being in their job description. But that's one of the practical difficulties that Sri Lanka is right now trying to overcome. Okay, so I cannot but talk about this. So with this, I don't know what is going to happen to our basic medical care, which includes the ketogenic diet. So just in summary, for thanking everybody who facilitated the administration of the ketogenic diet to the patients and the organizers of the workshop. Just in summary, so there are multiple practical problems, but like I have been talking about all these problems, we have a lot of help. Dr. Nathan, who has been actually repeatedly helping us with workshops as well, is always available, always there to help anybody who's willing to start the ketogenic diet. So all these problems are quite easy to overcome if you do have the commitment and the manpower to start a ketogenic diet program. Thank you.
Thank you, Dr. Pyara Ratna Jaike, for your excellent talk on the practical problem of setting up a KD clinic in Sri Lanka. And I think we all Southeast Asian countries face more or less the same problems. So probably your talk would be an eye-opener, not only for countries like Pakistan, India, Bangladesh, Nepal. I'm not sure whether someone is actually attending this webinar from Nepal, Bhutan, Maldives or not, but I think it's an eye-opener for all these developing nations and developing countries. Thank you once again, Dr. Pyara Ratna Jaike, and I'm sure we all help you, and even in subsequent years, we'll take advice from your experience in establishing KD clinics in our countries.
Thank you. Thank you.
So, I think we quickly move to our third talk. Sorry for my sore throat. At the moment, I'm facing a bad sore throat, probably from the 6th or maybe the 7th wave of COVID in the region. So the third talk is about the choice of KD therapies and the diet initiation. And the speaker is no other than but Dr. Mayfad Sahita Nasser. Sorry for maybe the wrong pronunciation. She's from Egypt, and day before yesterday during the organizing committee meeting, or maybe the speakers meeting, which was a short meeting organized by Dr. Janet, she was correcting our pronunciation, but sorry for once again if I pronounce it wrongly. Professor Nasser is Professor of Pediatrics at Faculty of Medicine in Shams University, Cairo, Egypt. She's with a special interest in clinical nutrition. Again, like all our colleagues, she has a long CV with dozens of publications and a long list of international presentation. But to cut everything short, she has a vast experience of teaching and training all across Egypt. But her main area of teaching and training is in Shams University. Shams University has a very specific history. It is one of the oldest university in Egypt, founded in 1950, and the third oldest with its first name, Ibrahim Pasha's University. And she's working there for the past so many years. Without further wasting time, I will invite her to speak on the topic of choices of ketogenic diet therapy and the dietary initiative. Over to Dr. Nasser.
Assalamu alaikum. It's an honor and it's pleasure to be with you in this prestigious event. My talk will be about the ketogenic diet choice and initiation. My name is May Nassar. I am professor of pediatrics and consultant of pediatric clinical nutrition and metabolic disease, Children's Hospital, Faculty of Medicine, Ain Shams University, Cairo, Egypt. I have master and doctor degrees in pediatrics and have master in clinical nutrition as well. Let me tell you that in my presentation, I will have a quick view about the ketogenic diet principle, but I will highlight the types, the choice, and of course, the initiation. Now, as an introduction, let me tell you that ketogenic diet has been known in the past, it's there in the present, and there is a role of it in the future. In the past, fasting and other dietary regimens have been used to treat epilepsy since at least 500 BC. For the present, a significantly positive outcome with the use of the ketogenic diet in children and even infants for treatment of drug-resistant epilepsy and beyond. Regarding the future, there is an unstoppable trend from the medical community, well, actually to the fitness world, not to mention a potential cure for cancer and many more other indications awaiting evidence-based medicine verification. Now, let me take you through a ketogenic diet journey, which starts by the proper patient selection. Then there is the pre-diet counseling and evaluation. Third is the diet choice and initiation, which I'm going to concentrate upon in my presentation, followed by the evaluation and monitoring after initiation, then managing the ketones and dietary issues. There comes the follow-up of the patients, and finally, the decision to discontinue. At the Children's Hospital and Shams University, we have a protocol for ketogenic diet initiation. Actually, it's under press, it's El-Rashidi et al., and I'm proud to be one of the authors. So our journey starts by patients referred to the Complex Epilepsy Committee at Ain Shams University. Of course, the referral is by neurologists and metabolic experts. If the patient is a good candidate without any contraindication, he's referred to the keto clinic. Otherwise, the referral can be either to epileptic surgery if he's a candidate or even vagus nerve stimulation. So if the patient is fit for ketogenic diet, according to the lab and nutrition data, counseling starts. And if we get the consent of the parents, then assessment would follow. Otherwise, of course, the patient is back to the epilepsy clinic. Now, referral of the patient to the clinical nutrition specialist is done for diet assessment and recent lab as well. Then we start to select the diet and initiate. We initiate as an inpatient unless critical or the patient is less than 1 year old. Otherwise, we have the gradual outpatient steps for older, stable patients. We follow up the seizures and we do fine-tuning of the diet. Then after 3 months, we can decide whether to continue or not. Of course, this depends upon the response. Responders, this means more than 50% improvement, can continue with monitoring. If it's for epilepsy, it's around 2 years. And if it's metabolic disease, sometimes it's for life. But even for epilepsy, after these 2 years, we can do gradual withdrawal or just continue for benefits other than epilepsy, like cognition and behavior. And of course, for non-responders, after the gradual withdrawal, back to the epilepsy clinic again for further assessment. Now, regarding the choice of ketogenic diet, which I'm going to talk about, choice means right patient and right diet. So for the right patient, what do? We make sure that the indication is right and the patient has no contraindication. And this slide sums it all. For the epilepsy, we have the refractory or what we call drug-resistant epilepsy. And of course, neurologists know that West syndrome, Otohara's, and focal seizures waiting epilepsy surgery have a very good chance with the ketogenic diet. Regarding the metabolic diseases, we have the GLUT1 deficiency and the pyruvate dehydrogenase deficiency, of course, the mitochondrial disease as well. How about the contraindications? We have absolute and relative. For the absolute, it's the fatty acid oxidation deficiencies, the ketolysis and ketogenesis defects, porphyria, pyruvate carboxylase, prolonged QT, insufficiency of liver, kidney, and pancreas, hyperinsulinism, and of course the glycogen storage disease, except for type 2, in which we can apply the ketogenic diet. How about the relative? The relative is the inability to maintain the diet or having reflux or growth retardation, non-compliance, sometimes surgical focus identified, or familial hypercholesterolemia. Now, are there other indications for ketogenic diet other than the epilepsy and metabolic? Yes, actually the scope is very wide. Now, Alzheimer's disease, type 2 diabetes, and cancer, all these diseases, ketogenic diet has been used. Let me take you through some publications, and this one from 2019, it mentions the role of ketogenic diet in Alzheimer's disease and highlights the benefits in enhancing mitochondrial function and cellular metabolism. Actually, ketogenic diet is associated with improvement in cognition in elderly with Alzheimer's, depending on the level of ketosis and its duration, of course, with the best results if it started early in the disease. There is a publication from 2022 mentioning the therapeutic effect of ketogenic diet in type 2 diabetes, and it's not the only publication. There are several publications all mentioning how can ketogenic diet show positive treating efficacy. As for this publication from 2020, it mentions the role of ketogenic diet in cancer therapy, how it can be an adjuvant to the classic anti-tumor therapy, and how it can, of course, affect the proliferation of tumor depending on the type. Application of ketogenic diet to cancer patients is generally well tolerated and enhances their quality of life. Okay, at this particular point, we're going to talk about the types of ketogenic diet available. We have the classic ketogenic diet. We have the medium chain triglyceride diet. We have the low glycemic index diet. We have the modified Atkins diet. And we, of course, have some adaptations like the targeted and high protein keto for athletes and bodybuilders. And we have what's called hybrid diet, in which families can take some of the characters of one with the other, but actually what you have in front of you are the known types. For the classic ketogenic diet, we talk about what we call ketogenic ratio. In this diet, the grams of fat are usually compared to proteins and carbs combined. So when we say ratio of 4:1, it means for each gram of carb and protein entering the body, 4 grams of fat has to be given as well. The higher the ratio, the lower allowed amounts of proteins and carbs. It typically ranges between 2:1 and 4:1, and the higher the ratio results in higher ketosis and probably with higher response. Individuals can respond differently if given the same ratio. And the goal ratio is typically 3:1, especially in infants and young children. And to measure the success, we measure the serum beta hydroxybutyrate, which is typically around 3 millimoles per liter in order for the diet to be effective, or the urinary ketones, which should be between +2 or +3. This illustration in front of you can give you an idea about the macronutrient distribution range in a typical human diet. It's half carb and the other half is between the fats and proteins. But have a look about the ketogenic diet. It's almost like 80% of fat and less than a quarter of the combined proteins and carbs. So going to the modified Atkins diet, it is a less restrictive version. The fat is still high, the carbs are still low, but the proteins are moderate to high without calorie restriction. The ratio is typical 1:1 or 2:1. Many research report success rate close to the classic. It's more tolerable, especially in children. If we look at the illustration, we already know how the ketogenic diet looks in comparison to the standard, but have a look in the middle about the modified Atkins diet. The fat is still high, but not as high as the classic. We have now like a very good portion of protein in our diet, but still the carbs is low, not as low as the classic, but still compared to the standard, it is low. This publication from 2017, it's in the Acta Neurologica Scandinavica. Well, I co-authored this publication. We talked about our experience with modified Atkins diet in children with epilepsy in Egypt after classic ketogenic diet failure. We gave them 9 months, the patients, modified Atkins diet, and the results were marvelous in terms of epilepsy control and the quality of life of the moms. The modified Atkins diet is recommended actually in drug-resistant epilepsy. And we put a special condition here in patients who cannot tolerate classic ketogenic diet. Please think of the modified Atkins diets in the pediatric age group. Now to the low glycemic index diets. The ratio in this diet is like 1:1. We have 60% of fat, higher carb intake of like 40 to 60 grams, but using the carbs here has a condition. Only carbohydrates with glycemic index of less than 50 are allowed. Glycemic index is food effect on blood sugar. Many research reports acceptable success rate, more than 50% seizure reduction. Calculating the glycemic index of foods is difficult for some parents, so it's a little bit tedious and needs extra work from the dietitian. Usually there are many illustrations that we can use to teach the parents. This is one of them. We teach them about the food groups, and in each group, which are the types that has the lowest glycemic index, and we put a mark at the number 50. Anything below 50 actually can be used. Other than that, it's not advised. Now, to the medium chain triglyceride ketogenic diet. This has 70 to 75% fat, and mostly it's medium chain triglyceride. It has more proteins and carbs compared to the classic. The high MCT diet makes it less tolerable being full of MCT. Actually, it causes GIT issues. Infants can tolerate MCT diet, yes, but with a limit, because more than 25% MCT is very hard for them. Usually they can take 10 to 25%. So application of a full MCT diet in infants is almost always impossible. So how about the diet initiation? Let me tell you that ketogenic diet introduction can be done easily with either with initial fasting or the non-fasting gradual method. This publication from 2005 in Epilepsy sums the both methods, the fasting versus the gradual. It's a very interesting publication. It was a randomized clinical trial. And as you can see, this table sums them both. The fasting method, of course, starts by fasting. Fasting is done until the patient has got urine ketones appearing, blood sugar starting to fall, or he reaches the maximum time of fasting, which is 48 hours. After that, they start giving him the full ketogenic ratio assigned to him, which in this example is 4:1, but the portions are, in the first day of introduction, 33% only from the total caloric needs. Then the second day, it's 67%. And then when he reaches the 100%, he can be discharged the following day. Compared to the gradual introduction, in which there is no fasting, and we start by the full caloric needs, the 100%, given in a ratio 1:1 in the first day, then the ratio can be increased to 2:1 in the second day, 3:1 in the third, and then if he reaches the full classic ketogenic diet of 4:1 the next day, the patient can be discharged. Well, this publication concluded that the data suggests in infants with intractable epilepsy, a gradual initiation results in fewer adverse events and is tolerated better overall while maintaining the efficacy of the ketogenic diet. This is another publication from 2005, actually mentioning the non-fasting ketogenic diet in their retrospective study being equal in efficacy, and introducing it actually gave the patients a better better tolerance than the initial fasting method. And this is another publication from 2004 in Pediatrics, also observing the initial fasting versus the gradual non-fasting and mentioning that the gradual is better tolerated and with better results. In 2004, there was a publication. Of course, it still favors the gradual initiation without fasting, but it just added a little information that an outpatient basis for introduction is feasible by this gradual method. There was no fluid or caloric restrictions, which meant that the patient can tolerate the diet well. Of course, there is an exception to what I said about the outpatient basis, because infants less than 12 months should be admitted to the hospital. And of course, any critical patient should be admitted. And diet initiation in the infants should be undertaken without fasting in a stepwise, starting by a ratio 1:1. We build up to the classic diet of 3:1, which is almost the maximum the infant needs. Of course, we can adjust it even to a lower ratio of 2.5 or 2:1. Sometimes, exceptionally, we can exceed the 3:1 ratio, but if this is done, we can actually, we must follow up the patient very closely because this is a crucial age. And of course, if we resort to any ratio above 3:1, we have to take care that the protein intake might be low and would not support proper growth. Luckily enough, we have a ketogenic diet formula in the market with a ratio 3:1 ready to be used for this vulnerable age group, either alone or combined with the breast milk if the patient is not in need of the full 3:1 ratio. For the initiation to be easy, this was a suggested regimen based on the total caloric needs per day. If you go on giving at the first step, which can take up to 1 or 2 days, 75% of the energy from the regular formula compared to 25 from the ketogenic, and step up from there to 50-50, then 25-75, then 10% from the regular formula compared to 90 from the ketogenic formula, and finally, you give the whole caloric needs from the ketogenic formula. Let me take you to another table, more informative, because this table gives the same steps and shows you the ratio of the ketogenic diet in each step. As you can see, we step up to 1.41 in phase 3, and then it's close to 2:1 in phase 4, and then we are in the ratio of 3:1 in the last phase. Now, I'm sure you have the question asking me why the need for phase 1 and 2, because when I explained the diet introduction, I said we start by a ratio 1:1 and increase from there. Let me tell you that these first 2 steps are very important. It gives the infant a chance to tolerate the diet better, actually to accept the taste, and for the GI function to work properly with the increasing amount of fats. If you just take him straight to 1:1 ratio, this might not be feasible. And of course, just calculating based on the energy needs is much easier for those who work with this vulnerable age group. So let me take you through the summary, and I'd say that the ketogenic diet choice is all about giving the right diet to the right patient. Indications of ketogenic diet is drug-resistant epilepsy, GLUT1 deficiency, and metabolic diseases, but there are more indications which are acknowledged as the Alzheimer's disease, type 2 diabetes, and cancer patients. The preferred ketogenic diet initiation method is the gradual non-fasting one, which should be done as an outpatient service unless the patient is below 1 year of age or in a critical state. Well, these are my references, and I thank you very much for listening, and I'll be ready for any questions regarding this presentation. Thank you again.
Thank you, Dr. Nasser, for a very nice and elaborated talk about the choices of ketogenic diet. And during the organizing meeting, I was discussing with Janak about organizing a physical meeting in sometime in India, but probably after having your talk and listen a lot about Egypt, I would love to have such kind of meeting in sometime in near future in Egypt as well.
Well, you're most
So-
welcome, sir. We are looking forward to this. You are most welcome.
Thank you. So quickly move to the last talk of the session, and that would be on pre-diet screening and food diaries. And a wonderful speaker from India, she's Vidola Naik Rani. She's MSc in clinical nutrition and dietetics. She had a huge experience of dealing with children and adolescents with ketogenic diet therapies. She's a clinical dietitian with specialized in ketogenic diet therapy, served as a research assistant and lecturer at P.N. Doshi Women's College in Mumbai. So once again, I welcome Vidola Naik Rani from Mumbai, India, and she will speak on pre-diet screening and food diaries. Over to Vidola.
Hello everyone, myself Vidula Rani. I'm working with Dr. Nathan. Today we will be discussing about different aspects which we need to consider before initiating the ketogenic diet therapy. So this will help doctor and dietitian to understand patient's present condition, accordingly, type of treatment, patient or caregiver's understanding level, their expectations and approach towards the treatment. So pre-KD screening is very important to develop rapport between doctor, dietitian and patient or caregivers, which will help for the smoother therapeutic process of ketogenic diet initiation. A multidisciplinary team approach is required, which includes trained neurologists, dietitians, neuropsychologists, EEG technicians, etc. There are various aspects which we need to consider before initiating the treatment of ketogenic diet. Clinic visits prior to the initiation of the treatment is required. Purpose of this visit is to identify seizure type such as either clonic seizure, myoclonic seizure or atonic seizure. Then all current anticonvulsant medications and or supplementation need to check for their sugar content. Evaluate for the patient's present coexisting medical conditions, either history of renal stone or patient has any swallowing difficulties, any gastrointestinal problem or constipation problem is there, which need to check. Counseling is another aspect which plays very important role during this process. We need to provide information about the diet, how to start and how to continue with the diet, which we need to guide. We need to talk with the family members about their expectations, make them clear about the efficacy rate of the diet, then adverse effects of the diet, which will help to reduce the dropouts. Identify their behavioral personality traits, which either fear, anxiety, or autistic features in children, aggression, which may challenge successful administration of the diet. Consider psychosocial and financial barriers to use the ketogenic diet therapy as well. There are various social platforms available, such as websites, videos, publications, which will be helpful to encourage patients as well as caregivers. Pre-KD counseling provides opportunity to involve family members, especially primary caregiver, who source, prepare, and serve food to the patient. Assessment of the family needs help them to gather resources. Contacting other families for the parent-to-parent support is required. We need to take anthropometric details before initiating the ketogenic diet process, which includes height, weight, ideal body weight as per country-wise guidelines, head circumference of the infants, and body mass index. Dietary aspects. A 3-day food record should be noted prior to the ketogenic diet treatment initiation, which will help to estimate current caloric intake and future caloric needs. Establishment of the dietary information, which includes either oral feed or enteral feed or combination of both, which have to decide. Then type of diet which we need to begin with, like classic ketogenic diet or modified Atkins diet or medium chain triglyceride ketogenic diet or low glycemic index treatment. Calculation of calories, fluid, ketogenic ratio, in which percentage of MCT oil or total carbohydrates per day need to calculate. Prescribe them vitamin and mineral supplementation as per the dietary reference intake. Make sure that caregiver understand their role to administer ketogenic diet therapy, which include time involvement for meal preparation, as they have to cook patient's food separately and separate food for the rest of the family members. Inform them about the cost of the foods and additional supplementation which we need to begin with. Also, the side effects of the diet, which either nausea or vomiting, which might be because of higher ketosis, food allergies or any food intolerance, and cultural or religious preferences that need to consider while making the meal plans. These are the different dietary assessment methods which we can use to collect the dietary information, which includes weigh food records, food diaries, 24-hour dietary recall, and food frequency questionnaire. Weigh food record. A detailed record kept of the weight of the ingredients, cooked food, and leftover food. This is the most precise method of dietary intake. Food diary or dietary record. Use weighing scale to record intake in grams. Record the intake of food and beverages consumed for 3 to 7 days. 24-hour dietary recall, in which make a list of food consumed over the previous 24 hours. Note quantity, brand name, and preparation. It is you can collect information by face-to-face interview or by telephonic communication. It is useful for literate or illiterate population as well. Food frequency questionnaire. So in which participants are given a list of foods and are asked them to rate how frequently the foods are consumed. That is daily, once per week, or once per month. Obtain portion size information by using household measurements such as small, medium, or large. It is relatively easy and inexpensive. Laboratory tests need to be done before initiating the diet. It includes complete blood count with platelets, fasting blood glucose, electrolytes such as sodium, potassium, chlorides, serum bicarbonate, total protein, calcium, serum liver or kidney test, which includes albumin, blood urea nitrogen, and creatinine, fasting lipid profile, serum acylcarnitine profile, vitamin D level, urine analysis, anti-seizure drug levels if it is required, EEG and MRI of the brain. Neuropsychological assessment can be done by psychologists to assess the growth and development and brain development of the child. So here I would like to conclude that counseling plays a very important role before initiating the dietary treatment. Laboratory investigations need to be done, need to discuss potential side effects of the ketogenic diet therapy, explain them about which diet to start with and how to initiate the ketogenic diet. Before starting the diet, patient need to maintain seizure diary so that it will helpful to decide further changes in diet or either in medications. So to start with KD, it is very important to understand multidisciplinary team approach so that each aspect of the evaluation can be considered carefully to ensure compliance from the patient as well as from the caregivers. Thank you.
Thank you very much. Very nice, detailed and elaborative talk by Vidola. So hence we conclude this scientific session comprises of 4 talks about the ketogenic diet, and now another 10 minutes for questions and answer from the audience. At the moment, I have one question from one of the speaker, and I would like to read. Probably not shown in the question and answer. Yeah, it's not shown.
Dr. Tipu, I have Dr. Tipu, I have sent it to you on the chat box.
Yeah, so it's for Dr. Sujata. It's about clarification required, isn't for the classical KD in Sujata. Sujata's lecturer, she referred to 2.5 to 1 and 1.5 to 1 as a classic KD. So the confusion was between the combination of classic KD, whether it's 2.5 to 1 or 1.5 to 1. And the taking into the second component was taking into the consideration the difficulty in getting use of the diet. Can we start with low glycemic diet, modified KD, and gradually proceed to classic KD? If needed, will the response be the same? So this was the question for Dr. Sujata. Can she hear us, Dr.
Yes,
Sujata?
sir. Yes, sir, I'm here.
So can you please answer this query raised
Yes.
by...
Yeah. For the first question, usually we start classical ketogenic diet from low ratio and gradually increase. And if we could see the ketogenesis and ketonemia and ketonuria and seizure control, we don't need to go up to 4:1 ratio. So for my patients, I always start from lower ratio and gradually increase. If I could see ketonuria and adequate seizure control, I will stop at that ratio. And once we had seizure control, I will gradually reduce and leave it in the minimum ratio. And for the second question, I think, yes, sometimes it will be very difficult to convince the parents to start the classical ketogenic diet. So if we start low glycemic index therapy, and if they could see any improvement, they will be more motivated and will be more happy to continue with the diet, and we can gradually change the diet from LGIT to modified Atkins diet, and if needed to classical ketogenic diet. I hope this answered the question.
Yeah, thank you. I think the next question is for Vidola. What point should be considered in case of vegetarian patient? I think a very valid and pertinent question, particularly in the region where a lot of communities and the people with different ethnic background, they are vegetarian by dietary choice. So what points should be considered for those particular group of patients? Please unmute yourself. Vidola? Yeah, thank you.
There are many vegetarian options available like almond flour, coconut flour, then coconut milk, almond milk, even paneer, cheese. All these things we can consider while planning the diet. Even you can suggest for the patients as well while starting with the washout. Even in washout also we can use almond flour, coconut flour, which contains higher fat and low in carbohydrate. So we can consider that.
Okay, thank you. So you mean a lot of options. What I would like to know in extension of this question, though you mentioned a couple of paneer and coconut oil, but if we look into as a non-veg group, if you look into the options, don't you feel options for veg group is very limited and very small? And if someone is being recommended or asked to use this keto or modified keto, he or she will have a limited option and might not be able to continue for quite some time. In what's your experience?
We have
As we
many
haven't-
patients. We have many patients who are vegetarians, and
Okay.
there are a lot of options they can prepare at home. Like even with the flaxseed flour, almond flour, the combination of both, they can prepare a bread or burger bread like that. Many things we can cook with vegetarian food instead of even using non-vegetarian stuff. So we have to suggest them recipes with all the ingredients, then how they can modify the those recipes they can use, and how they can modify those recipes with vegetarian stuff.
Thank you.
Yeah, so wants to talk.
Dr. Tippu, can I add something?
Sure, please, sir.
So yes, so initially we had some problems. Whenever anything is new is begun, you do have problems. Because it began in the West, so there were just no recipes available. So what we did is we had a bank of about 100 recipes, which the dietitians actually made, ate, I also tasted, and then we would give them to the patients. So, and now we have more than 250 recipes across the board, vegetarian and non-vegetarian. We have more vegetarians than non-vegetarians on our service, and we have many people who have Jains, and now Jains are even more fastidious. They will not eat onion, they will not eat carrots, they will not eat potatoes, they will not eat garlic. So it's very difficult. But I think the bottom line is that it is doable. There is nothing which is not doable. You have now, luckily you have a wide choice. You can make your soya flour at home. So we have on our website, it's shown how to make it. We have almond powder, you can make at home. You have your flaxseed powder, and you can make a mix of these. So I think it's endless. I don't think vegetarianism is a bar to the ketogenic diet. I
Okay.
don't.
Thank you for your input. So I think there is no question. I think one more question. No.
Okay.
So
Can I
it's just a thank. So I think I would like to take this opportunity to once again thanks all my speakers, starting from Sujata, followed by Kiara Ratnajaike from Sri Lanka, and then Maya Nasser from Egypt, and the last speaker, but not the least, of course, Vidola from India. So once again, thank you all my speakers. Probably there is no question, and I'll hand over the mic back to Janak for his remarks about the session and any additional comments about all these talks, and to close the session. Over to Janak.
Thank you.
Janak, can you hear me?
Yeah, I'm just opening. I
Yeah.
just wanted to show one PowerPoint because this has come up mainly for that reason. I will share screen. That some have been asking about the training. So we started this Asian Institute for the Ketogenic Therapy in 2015, primarily to spread the use of ketogenic therapy, and a website called as ketogenicdietindia.org. So under this, we have a 1 month training for doctors and dietitians. It was earlier 3 to 4 weeks online and 1 week training at our own center. I'm so sorry. So that was how it was, that there was a hands-on practical training in our center for a week, and there would be in the first 3 weeks all the theoretical knowledge and then the practical knowledge. However, during the pandemic, I think the one good thing we learned is that we don't have to be in the same region, we don't have to be in the same room, we don't have to be in the same country, we don't have to be in the same continent. So we have trained people from all over the world online, and I think this is working very well. And because it's such a long course, I think they have a fairly good knowledge, both the theoretical and the practical knowledge, where we actually show them patients, we show them how they are fine-tuned, we show them how they improve, so they can interact with the patients and with also the caregivers. So I just wanted to put this out for all those participants who may be wanting to begin a ketogenic diet center. And now is Dr. Sakina, has she joined? Dr. Sakina was supposed to be the moderator for the next session. But since she hasn't joined, okay, so we'll have to just go on to the next speaker. And I think Dr. Saima will put up the next